Very good morning once again. So we'll be beginning the scientific sessions immediately. Once again, a gentle reminder for all the speakers, kindly keep in within your stipulated time. The time for each session is 12 minutes for the presenter and 3 minutes for discussion. The first session, Beyond the Bulge, Advances in Hernia and Abdominal Wall Surgery. May I please invite the chairpersons for this session, Dr. O.T. Mohammed Bashir, Professor, Department of General Surgery, KMCT Medical College, Calicut. Dr. Dinesh Babu, Professor, Department of General Surgery, Malabar Medical College, Calicut. Dr. Vijy Paul, Professor, Department of General Surgery, Malabar Medical College, Calicut. And Dr. V. Suresh, Senior Consultant, Department of General and Laparoscopic Surgery, Koil Hospital, Kannur. I invite the chairpersons onto the dais, please. Dr. Mohammed Bashir, Dr. Dinesh Babu, Dr. Vijy Paul, and Dr. Suresh. The first presentation is by Dr. Vijy Paul Thomas, Professor and HOD, Department of General Surgery, MOSC Medical College Hospital, Kolanjeri. His topic, strategic selection, how to choose the correct procedure for inguinal hernia repair. Once again, with the kind attention of the speaker and the chairpersons, 12 minutes presentation, 3 minutes discussion. Over to the chairpersons. Thank you.
Good morning all. Today's opening batsman is Vijy Paul sir. And presenters are all my teachers, Govi sir, Lashman sir, Saji sir. Sir, please start.
Respected chairpersons, senior colleagues and senior teachers and colleagues, it's a privilege to be the opening batsman, like sir just said, at this mega surgical event. And I must thank the whole team led by Dr. Srijayan for giving me this opportunity and for allowing me to open the innings for this CASICON 2024. Now, my topic is basically on inguinal hernias, how to choose an appropriate procedure. Now, when you talk about inguinal hernias, we all know inguinal hernias are among the most commonly performed surgical procedures the world over in general surgical units. Having said that, there is still a significant percentage of recurrences and a significant percentage of post-operative inguinal pain. And about a quarter to half of the gentlemen sitting here in this audience, as well as around 3% of the ladies, are going to develop an inguinal groin hernia sometime during their life. So it was this background that the hernia surge group was formed by the different hernia societies, the European, the American, the Asia Pacific, and the International Endo Hernia Society. And they all joined together to form hernia surge guidelines in 2018, which was updated again in 2023, in order to improve outcomes in inguinal hernia repairs. And it is based on these guidelines that I'm going to make this presentation today before you. Now, when we talk about choosing the right procedure in an inguinal hernia, there are a lot of distractors that we have to face, more than what the textbook actually wrote. You know, we have a patient who's Googled well and who vouches for keyhole surgery. We also have a surgeon who's not trained in minimal access surgery. There are surgeons who work in top-end facilities. There are patients who are stuck in remote corners of the country with poor healthcare facilities. So the decision that we take doesn't necessarily always reflect with the guidelines that are available. So our choices are numerous. Now, when you come across a patient with a hernia, our choices are numerous in the sense we have many open repairs, right from the Bassini repair that first came in 1888 down to the robotic tap that is available now. We have a whole lot of options with meshes. But what is the implication of all this? An interesting study found that the rate of adoption of laparoscopy, despite there being indications, specific indications, were only 42%, and the females were at a disadvantage when it came to following guidelines with hernia repairs. So the first question that we need to do is to mesh or not to mesh. Now, there is a subset of patients who still insist on not undergoing a mesh repair even now, which might sound a bit surprising, unlike our usual clinical practice where patients don't usually crib about these kind of things. There is a subset of patients who think meshes have a disadvantage. There definitely are disadvantages like mesh migration, erosion, mesh allergies, seromas and all that, but the advantages far outweigh the disadvantages. And so, in terms especially of reduced recurrence and shorter duration of surgery and so on, so the recommendations definitely stand in favor of mesh repairs. So all male symptomatic adults with symptomatic inguinal hernia should undergo a mesh repair, and the mesh choice is usually a flat mesh. No great advantage with three-dimensional meshes, a PHS or a PP plug and patch and so on. So the dictum would be all patients can undergo a mesh repair, but interestingly, those who insist on non-mesh repairs or where a mesh is not available in those kind of settings, it's a Schuldeis repair that is supposed to be the ideal one, especially for L1, L2 and M1 primary indirect hernias in young males, as well as less than 3 centimeter defect indirect hernias in females after ruling out femoral hernias. So mesh repair for all, and if a non-mesh repair is being considered, it has to be a Schuldeis repair. And this is the web page of their of the Schuldeis Hernia Hospital, where they proudly boast that they are doing their hernias without the use of mesh, and they claim a very low recurrence rate. So once you have decided on the mesh part of it, then comes the appropriate surgical technique. You have a lot of surgical techniques that are available. How to choose one? Now, we all know inguinal hernias don't present as one particular clinical situation. Like, for example, there's one where you have a primary unilateral inguinal hernia in men. Now, what is different from the EHS guidelines of 2009 is that open Lichtenstein has gone to the second place, but the laparoscopy has come as the first place, primarily because of the lower risk of chronic pain and less postoperative complications. So the first choice here is going to be a lap, tap or TEP, and a Lichtenstein mesh hernioplasty as the best open alternative. Now, when it comes to women, there's a very interesting observation. There were very few RCTs available for them to make the recommendation. So they went through a lot of observational studies, and they found that, interestingly, many of these patients, females who underwent inguinal hernia repairs, came back with femoral hernia recurrences, less than the inguinal hernia recurrences. So they went into details of all those cases, and they deduced that it is probably because very many femoral hernias were being missed and inguinal hernia repairs were being done. So now the recommendation based on this deduction is that it has to be a laparoscopic repair for females in a unilateral inguinal hernia, primarily because of the beautiful view of the myopectineal orifice that laparoscopic repair offers. And if at all an open hernia is being done, in all of those cases, the transversalis fascia has to be mandatorily opened, a femoral hernia specifically looked for, and if present, the repair has to be converted into an open preperitoneal repair. Now, unilateral inguinal hernia in men, again, primary bilateral inguinal hernia, both in men and women, it's a clear choice. It has to be laparoscopy repair as a first option, mainly because of the advantages that laparoscopy offers in terms of earlier return to work, shorter hospital stay, and so on, plus the fact that it is significantly quicker to do a bilateral hernia through the same 3 keyholes than doing 2 separate open repairs. Now, when it comes to a scrotal hernia or an irreducible hernia, it's considered more of a complex problem. And the difficulty with laparoscopy, it is said, is that there is difficulty to ensure complete dissection of the sac. So what happens is if you leave a significant part of the sac behind, there is going to be a significant seroma. Secondly, the difficulty with dissecting the sac of the cord structures leads to increased chance of bleeding. So in these cases, they noted that there was an increased risk of secondary hemorrhage as well as hematomas, and so the procedure of choice in these cases is an open mesh technique, with the laparoscopy being reserved only for highly experienced MIS surgeons. Then, with primary inguinal hernia after previous pelvic surgery, no controversies. The plane has already been used up for the previous surgery, and so an open mesh Lichtenstein repair is the first choice. You have a set of patients with cardiac and pulmonary disease where they are poor risk for anesthesia. So the options are between a local anesthesia versus a regional anesthesia. And it has been found, as per studies, that with local anesthesia, there is less duration of hospital stay, faster return to work, and so on. So local anesthesia with monitored anesthesia care is the first choice. Spinal anesthesia is also an option. But there is a small caveat here in that with local anesthesia, if the surgeon is inexperienced in procedures under local anesthesia, there is an increased intraoperative pain that the patient experiences, as well as a slight increase in the recurrence rate. And with recurrent inguinal hernias, again, the recommendations remain the same. If it's an open technique that was done initially, you do a lap repair next. If it's a lap repair that was done first, you go for an open repair next. With incarcerated hernias, again, laparoscopy is now the first choice. What is suggested is that you go in, find out content, you reduce the content. If it's clean, you go ahead with whatever was planned initially, either a TAP or a TEP repair as was the initial plan. If there is intestinal resection that needs to be done, when it becomes a CDC 3 and 4, you have two options. One is you can close the hernial sac and come off and schedule the surgery for another date. Or you could close the hernial sac, come out, and then do an open repair. And finally, you have the robotic TAP. Now, robotic TAP is the latest entry into the long list of techniques that are available. Being the latest in the field, there aren't much of studies available to put it up in the recommendations, so it's not yet come into the recommendations, but the advantages are thought to be primarily that it gives takes away a lot of cognitive and physical stress for the surgeon. The learning curve is short for surgeons who are already experienced in laparoscopic repair. But on the flip side, you have a longer duration of surgery as well as the higher costs that are involved. So finally, to conclude, the most significant changes in guidelines compared to the previous guidelines has been that the laparoscopy has more or less kind of replaced Lichtenstein repair in most clinical situations as a first choice, with the Lichtenstein repair being the only open mesh technique that is acceptable. And if it is a non-mesh technique, it has to be a shoulder repair, where the problem is the long learning curve. And the interesting part is how long the learning curve has still not been documented in shoulder repair, because there's not much of places doing this procedure. And always remember, it has to be a tailored approach. It is always ideal that as surgeons, we should be proficient in offering both an anterior and posterior approaches. We should be trained in a laparoscopic approach as well as an open Lichtenstein approach. And obviously, the surgeon's skill and available resources are going to be the final deciding factor. The availability of meshes, the availability of the laparoscopic units, these are the things that are going to be the final deciding factor. But as far as possible, it is suggested that these guidelines should be followed. These are my references. Thank you very much for a patient listening.
Thank you, Dr. Vijy Paul, for the excellent and very informative presentation. And the now topic is open for discussion.
Sir, in unilateral hernia, NICE guideline says as the patient wishes. That's an indication for laparoscopy.
Okay. So in all of these cases, that is always given as a caveat, and there always has to be a discussion with the patient regarding the choice of procedure. But when you look at it as per the guidelines, now what they suggest is the laparoscopy as a first procedure again. In the previous guidelines, it was an open Lichtenstein repair, which was thought to be the first one. But now the hernia surge guideline says that it has to be a lap repair as the first choice.
Previously, the indication for laparoscopic repair was either recurrence or bilateral hernia. Now it is changing. Maybe in the future, this may be the first choice in the unilateral inguinal hernia.
Thank you, sir. That was quite an engaging and interesting talk from your side. By and large, the laparoscopic repair depends on the presence of mesh. We are all aware of that. Which is your choice of mesh?
I usually
ideal mesh, but what is your take on that? Which is
what is actually recommended is that the mesh has to be a flat mesh. Now, there is always a trend towards moving towards ultra lightweight meshes, but the guidelines say that there is a slight, although it improves the patient's comfort in the initial part, there is thought to be a slight increase in recurrence as compared to the conventional meshes. So if you look at it from the guidelines aspect, probably the ideal one would be a conventional polypropylene mesh.
Conventional monofilament.
Monofilament, polypropylene.
Macroporous.
Macroporous mesh, yeah.
Polypropylene.
Yes.
One more question from
Yeah.
my side is, if you happen to get a case with a ventral hernia, maybe one M3W1, for example,
Okay.
with an inguinal hernia, what will be your procedure of choice?
That goes beyond the scope of this topic, but if we got a ventral hernia with an inguinal hernia, after discussing with the patient, if the patient,
If you want to go in a single go, like in a single procedure, what will be your?
I would do the inguinal hernia part first, both laparoscopy, if the patient is okay with it. I would do the inguinal hernia part first and then do the ventral hernia part with an IPOM.
Both laparoscopy.
Both
Will
laparoscopy.
be IPOM and.
The other one, a TAP. I am a TAP man, I must confess.
So why do you consider TAP as an option for ventral and inguinal both?
That is also an option depending on where the defect is. If it is very low down, I don't know. I don't have an experience having done a case like that, but maybe that would be an option also.
Yes, sir. We do that. That's an ideal option. Instead of IPOM, we can save the cost of the
Okay.
mesh
Yes, sir.
and the tackers. That will bring down the cost
Definitely.
to a 45,000 for a patient.
Yeah.
So that's an option. It's open for discussion. Any questions from the floor?